Thank you, Padma, for this kind invitation to participate in this course and also your kind introduction. I hope I live up to expectations. So what is new? Well, I think other than femtosecond laser-assisted cataract surgery, we've also heard a little about Ozurdex, which we introduced at the end of surgery. Really little else. Okay, you just need to be a good surgeon. Okay, so pre-op assessment, we're still limited by the patient's visual potential. If the patient's macular or optic nerve are not functioning well, this patient will still not have a good outcome. What is important when you assess this patient is if a patient has brittle intraocular pressure that with just one glaucoma drop will suddenly crash, you have to actually bring this patient to the UBM to assess the state of the ciliary body before doing surgery, because this patient may have risk of hypotony if there is ciliary body atrophy. Sometimes you may find a suprachoroidal cleft and sometimes tractional membranes that you may want to go in with the vitreoretinal surgeon to settle. Important is the timing for surgery. We still want to achieve at least a minimum of 2 to 3 months of quiescence before doing surgery. And if you're dealing with a patient with Behçet's disease, preferably 6 months would give a better outcome. Now, we sometimes do see patients who present with a hypermature white cataract that you feel that you need to urgently bring to surgery. What we can do is to run an intravenous methylprednisolone. 1 gram, perhaps even 3 days before surgery is very severe inflammation, or what I find useful is to give it 1 hour just prior to surgery. The question of whether or not you implant an intraocular lens really depends on whether you are able to achieve optimal control of the intraocular inflammation. If this is achieved, then intraocular lens implant is not contraindicated. We certainly want to avoid silicone lenses and anterior chamber lenses. And recently, the American Uveitis Society has been discussing the topic of whether or not the lens implant should be in the bag. I mean, for cataract surgeons, we all know that when it's placed in the sulcus, there's a risk of inflammation from irritation of the ciliary body. However, in the uveitic patient, Gary Holland is actually a proponent of putting it inside the sulcus because he feels that actually the posterior synechia are less likely to occur because the posterior synechia tend to occur to the area of the capsular rim. So that's really out for debate at present. How about prophylaxis for patients before surgery? Certainly, if the patient has got an infective cause, you might want to consider anti-infective, for example, herpes zoster, herpes simplex, or CMV uveitis. But for a patient who has had previous inflammation that involved the macular or the posterior segment, you would want to consider giving some form of prophylaxis for surgery, especially if you have to manipulate the iris because of adhesions. Typically, even for non-uveitic patients, I would routinely give preoperative topical NSAIDs. Topical steroids may be given for patients with uveitis, and what I find is more important is intraoperatively what we can give. Certainly for all patients who are non-infectious, I would give an intracameral injection of 0.4 milligrams of dexamethasone. Previously, I used to consider giving intravitreal triamcinolone instead of oral steroids for the milder cases of uveitis, but today I am routinely using Ozurdex. Now, we know that Ozurdex generally, although the company states can last up to 6 months, in most of our cases would last about 3 months. And because inflammation actually is most severe in the first 6 months, even as you taper the oral steroids, if you gave it as a prophylactic treatment, generally the patient may relapse within the first 6 months. So what I've taken to is actually giving 3 monthly Ozurdex for the first 6 months in order to ensure that the inflammation induced by surgery does not cause a relapse of the inflammation post-operatively. The study actually that came from India actually showed that there was no difference in visual outcome, anterior chamber activity, intraocular pressure, or central macular thickness or recurrence, whether you give systemic or intravitreal triamcinolone prophylaxis. So let's look at some surgical videos. So if you have a small pupil, you can either stretch or cut. All right, you can see here release of peripheral anterior synechia that should be done before releasing posterior synechia. You can see this patient now, he's being stretched and it begins to rip. And you should not actually allow that iris to rip because it will be a permanent rip and it will break down the blood ocular barrier. So I would rather go to multiple sphincterotomies if you see it actually ripping. Now, if there is a pupillary membrane, I prefer to use a microforceps there, intraocular microforceps, to remove that membrane. And you'll see just by removing that membrane, the pupil will be unbound, And if you think that is not adequate with viscoelastic, you cannot dilate that adequately, you can then do these multiple sphincter cuts. But you make sure that the cuts do not extend into the constrictor. Okay, so you always remove the membrane to facilitate pupil expansion. Now, there are also small pupil devices that are available to us, and we're all very familiar with iris hooks that expand the pupil. What is important is that this portion is adequately expanded. You can do a diamond, or you can also add an additional retraction here so that it does not actually block you. And here you can see that a patient who's having a Beeler pupil dilator, which can be reused. Okay, and here a Myogin ring being injected in and then removed to expand that pupil. This retains a nice round pupil at the end of surgery, and surprisingly, so does the Beeler pupil dilator. So this actually is quite useful because it is something that you do not have to discard, and so the cost is really quite low because you're going to reuse it. They have got a 2-prong pupil dilator that goes through a 2.2 mm incision. And of course, from India, also Batashaji rings will soon be available, and that is able to go in through a 20-gauge incision. Now, what is important is that very often we are afraid of capsulotomy going out, so we make it small at the start, but it may be necessary after that to enlarge it at the end of surgery. Otherwise, you may end up with capsular phimosis, decentration of the lens, or even a lens because of capsular phimosis has dropped to the back of the eye that may require fixation, in this case to the iris. So what is the technique we use? Generally, because the pupil tends to be small, we want to avoid aspirating and phacoing the pupil, the iris, and so we want to do a technique that keeps your phaco tip within the center. Even with a dense cataract like this, with a corneal graft here from a previous infection, you can see that you can still complete the surgery through a pupil that size and not injure the iris any further. Cortical cleanup is very important so that you do not leave any antigenic material to cause further inflammation. And you can see sometimes it can be a bit more challenging. The pupil is not that large. What you do is actually you use your second instrument to help to rotate the eye around to give you better visibility of that cortex. And what is important is when you aspirate, you stay deep so that you do not aspirate inadvertently the iris there and cause it to close down further. So let's look at femtosecond cataract surgery. So we have this patient here who has had chronic uveitis in the past and is now quiescent and has got very, very dense cataract because he's had uveitis for so long and we've been holding off. And I thought he might benefit from femto. So after opening up the pupil with a Myogin ring, I sutured that eye and brought him to the laser. All right, so this is in a different room for us. We are using the Technoless or the Victus by Bosch and Lomb. And after doing the laser, I brought him back to the operating room, stained the capsule to visualize it because it's a very dense cataract. And you can see it was complete capsulotomy. The Myogin ring was still in place at the time of the femto to keep the pupil open. And this suddenly is a very, very dense cataract that actually, if you had just done this patient without the femto, you would have struggled with that dense cataract. And many of these patients from the chronic inflammation, secondary raised pressure from uveitis may have a decreased endothelial cell count. And you can see even from the amount of energy I'm using, the cornea is getting a little steamy. So it's important in these cases then, of course, to top up with more dispersive viscoelastic. But you can see that without the femto laser, it would have been far more difficult for me to complete a case like this. So the femtosecond laser is not for every patient, but certainly for patients where I think would be a great advantage when they have a small pupil. It can be expanded with the Myogin ring to prepare them for the laser. So the question that has been asked to me is femto better for uveitic eyes? Certainly, if you are worried about the endothelium, it does use less energy. This is the manual group compared to the group having femtosecond, and this is significantly different. In terms of flare, looking at the change in flare from baseline to post-op at 1 day, 1 week, 1 month, actually there is really no difference between the manual and the Victus flare in these patients that are non-uveitic, they're just normal eyes. But of course there's a definite benefit in terms of having that correct size and shape and centration using the femtosecond laser. And what I found was interesting was that when we look at the capsulotomy diameter 1 day, 1 month, 1 week and 1 month, the cases that had the femtosecond treatment, actually the capsulotomy did not change. And this was significantly different from the manual group. And perhaps this may be useful in preventing capsular phimosis that we see quite often occur in our uveitic eyes. And does it give better vision? Certainly for patients who have good visual potential, we did find that our patients with femtosecond laser achieved significantly better vision at the 20/25 level. And this is currently in print in the AJO. And also, when you look at the overall vision with the femtosecond laser, it was significantly better unaided visual acuity. And how about refractive predictability? We did not find significance for the mean absolute error, but the manifest refraction spherical equivalent was significantly better in the femtosecond laser compared to controls. So other than all that interesting technology that we have available, what is very, very important is actually the postoperative management. Intensive topical steroids, oral steroids if necessary. Sometimes the patients become a little hypotenuse. I've actually had patients that have done very well with the Ozurdex that perhaps I had decided not to give at the time of surgery. You can actually help the hypotony. Topical NSAID should be continued for maybe 2-3 months. These patients are best monitored with the laser flare meter and OCT looking at the macula for edema. And if there are any complications, they should be treated aggressively to prevent recurrence and hypotony. So in conclusion, small pupils can be enlarged by releasing synechia, removing membranes, and stretched or cut. Pre- and post-operative control of inflammation is crucial to achieving a good visual outcome in uveitic eyes. Femtosecond laser may be beneficial to patients with dense cataract in spite of small pupils. Thank you.
Thank you, Professor Chee.